So I practice in Seattle here. So Isthmic spondylolisthesis is a little different than degenerative spondylolisthesis. It's often discovered at a younger age, and people usually complain of back pain, leg pain, sometimes neurological deficit as well. And it typically involves L5 nerve root. And if you neglect that, typically patients start losing a sagittal balance, and decreased sagittal balance is associated with decreased health-related quality of living, HRQL. So it was Schwab et al. In 2010 in Spine described how age-related decreased lumbar lordosis is compensated with increased pelvic tilt and decreased sacral slope, so one can maintain level gauge. In Isthmic spondylolisthesis, the situation is a little different. As a lumbar spine starts subluxing in relation to the sacrum, this decreased lumbar lordosis as time goes by is not compensated by decreased pelvic tilt, increased pelvic tilt. In fact, sacral slopes start increasing as the lumbar spine sort of kicks the sacrum to the back, and the pelvic tilt, in fact, decreases. But nevertheless, lumbar lordosis to pelvic incident ratio remains low, and it is associated with decreased health-related quality of living. So some authors advocate just fixing the Isthmic spondylolisthesis as it is without correcting this sagittal balance. I think it is a mistake, because if you do that, then patients still going to have a compromised sagittal balance, and it also affects the proximal level degeneration as well. So typically, this is what you see. As you can see, that this patient has loss of reduction and non-union with a pedicle screw fixation, pedicle screw fracture, and this person also has proximal segment degeneration as well. You know, something like this, it just makes someone like me who has to fix the problem later on. So I think it's important to restore the sagittal balance. Surgical approach, there are many, and typical approach is posterior stabilization, and the gold standard used to be gill decompression and fusion, but muscle dissection is quite extensive, and EBL is quite extensive with this. You could do MIS TLIP procedures nowadays, but it has been my experience that reduction of the deformity was not very satisfactory. You could do anterior stabilization plus minus instrumentation, but when you just do anterior stabilization and you don't get a good rotational stability, and you need an approach surgeon as well. You could do the circumferential fusion, and again, you can avoid extensive muscle disruption and increased blood loss with this approach. And it's quite inefficient. You have to flip the patient in the middle of the case, and also you need an approach surgeon for this as well. So in my practice, I usually take care of this problem with OLIF, and I've done many OLIF procedures, as Dr. Rowe mentioned, and if there's any instability, such as isthmic spondylolisthesis, deformity, and if there's a multiple level degeneration, and if there's osteoporosis, I typically back my OLIF with the percutaneous pedicle screws. And I do OLIF with the percutaneous pedicle screws while the patient is still lying in the right lateral decubitus position in single spine surgery. And if this is less than 2 levels, and it is quite efficient approach in my mind, because you don't need any approach surgeon for these procedures. And because you are doing this procedure using the OLIF, you don't need it in any IOM. And percutaneous pedicle screw fixation is usually done ipsilaterally and unilaterally. And if it is up to 2 level, and my experience shows that it's quite stable, and it's almost as good as putting a bilateral pedicle screw fixation. And it is efficient because you don't have to flip the patient in the middle of the procedures, and because it is minimally invasive spine surgery, blood loss is very minimum. In oblique lumbar interbody fusion, OLIF, as you know, is interbody fusion technique which is taking place using a pre-psoas approach. It is being done in front of the lumbar plexus. It is done in front of the psoas muscle. The advantage of the OLIF, in a sense, is quite similar to the common L-lip procedure, such as X-lip and a D-lip procedure, because you are putting implant with a large footprint. So you get a less chance of a non-union and graft subsidence. And also, you are putting this implant in the strongest part of the vertebral body of a facile bone, so you can actually really jack up those two vertebral bodies apart from each other and to take advantage of ligamentotaxis and facet destruction. The true advantage of the OLIF procedure is the fact that it is being done in front of the psoas muscle and in front of the lumbar plexus. Well, number one, because you are doing this in front of the lumbar plexus and psoas muscle, and then you are doing this lower part of the iliac crest, you don't have to so much worry about approaching L4-5, because with the OLIF procedures, you are doing this procedure at the highest part of the iliac crest. With the OLIF procedure, you are actually doing a relatively lower part of the iliac crest. And the true advantage is you are doing everything in front of all these nerves. What does that mean? Because you are doing this procedure in front of the nerve, you don't have to worry so much about damaging lumbar plexus. So you can get quite aggressive with the large implants, taking true advantage of the ligamentotaxis and facet destruction. This is usually my setup, and a patient's placed in right lateral decubitus position. I make incision about 4 centimeters anterior from iliac crest. The length of the incision is about 5 centimeters long. That's my setup for retractor. Dissection is done in layers. After skin cutting, I go through external oblique aponeurosis, internal oblique aponeurosis, until I can find the yellow retroperitoneal fat. Oops. Right there. Then I simply point my finger towards the iliac crest, and I detach and liberate and peritoneum anteriorly. And I put a retractor in there and do the annulotomy. With a cup elevator, I separate L5 and S1 vertebral bodies apart from each other and dilate it with wedge and then trial and bigger trial and put an implant in there. And I'd like to use anterior plate for stability. And then I turn around and make an incision in the back. I'm still old-fashioned. I like to use a K-wire, and jam shitty and K-wires placed. And cannulated pedicle screws placed, and it's connected with a bar on the one side. This is one of my patients. This is a 34-year-old lady who's quite athletic, and she's a surfer, and she's a volleyball player, which is quite unusual in Washington State. And she's been having chronic back pain since she was involved in MBA as a teenager. She has a neurological deficit as well. She tried everything to stay away from the surgery to no avail. This is a spondylolisthesis of L5S1. You can see there's an obvious defect in the pars intraarticularis. And when she flexes forward, it subluxes 11 millimeters. And when she extends, it returns to a 9 millimeter subluxation. That's an MRI. You can see that there's a severe neuroforaminal stenosis and a modic change involving L5 and S1 vertebral bodies. And this was treated with the OLIF of L5S1 with a unilateral pedicle screw fixation while the patient is still lying in the right lateral decubitus position. Surgery took less than 2 hours, and EBL was less than 30 cc. And she stayed in the hospital overnight and went home the next day. And I saw this lady actually yesterday for 1 year post-op follow-up, and she was doing very well. I don't know if she was going to go back to surfing, but she told me that she's pain-free. And this is another athletic young lady, and she's been having chronic back pain since she was 10 years old. And she also has a neurological deficit, and she failed all of non-surgical measures. And these are 2 X-rays obtained 14 months apart. Look at the progression of the spondylolisthesis. And on the left side, you have some disc space, and you have maybe a grade 1 to 2 spondy. On the right side, you don't see any disc space at all. That's an MRI, again, severe disc degeneration and severe neuroforaminal stenosis. And again, this was treated with the OLIF of L5S1, the percutaneous pedicle screw fixation, which was placed ipsilaterally. EBL was less than 30 cc. Surgical time was less than 90 minutes, and she was kept in the hospital overnight, and she went home the next day. Now, this single
Sean, can I ask you a question?
Yeah,
do you
go
always
ahead.
approach it from the left side?
I do. And it is because if you're going to do OLIF just 5S1, you could approach from the right side as well. But if you're going to do the OLIF, not just the 5S1, if you're going to do 4-5, often it is more advantageous to approach from the left side because of the location of the vessels. So as you start doing other levels of OLIF from the left side, you kind of get used to it. So you could try this from the right side, but I'm more comfortable approaching from the left side. But there's an advantage of approaching from the right side because you don't have to deal with a common iliac vein. You just have to deal with the common iliac artery. As you know, that the artery is harder to injure than the vein. So there's some challenges. Now, single position spine surgery is my passion nowadays. I try to do everything while the patient is lying on the right lateral decubitus position without the flipping patient. The challenges are anatomic and radiographic. When you try to beam the X-ray beam such a way so you can put a good AP view in the S1, sometimes it can be quite difficult and ergonomic. And you try to put a contralateral side of the screw, sometimes it isn't necessary. You have to approach from the bottom up, and it can be quite tiresome and biomechanical. And if you try to do more than 3 levels, again, it's probably a good idea to put bilateral pedicle screws. If you try to do that, and because of the region that I mentioned, it can be quite challenging. So this is an example. It's a 55-year-old lady, and she's a horse trainer, and she's been in chronic back pain. Again, she failed all conservative measures. And this is her X-ray. She's got almost grade 3 spondylolisthesis, which is subluxus with a flexion and extension. That's an MRI. So this is what I did. And as you can see, reduction is good, and the disc spaces is nicely elevated. And I was able to take care of this OLIF and a percutaneous pedicle screws. But notice that how much of a sacral slope she has. It's quite significant. So in this case, in order for me to perform this OLIF, took less than half an hour. Putting these pedicle screws so I could get a bullseye of the S1, it took a lot of time. It took more than 45 minutes to do this, just to put 2 pedicle screws. You know, far cry from, was it a Dr. Oskuyan who put 2 pedicle screws in 15 minutes?
No, why was it difficult to visualize?
It's because of the patients lying in this right lateral decubitus position. In order for me to put a percutaneous pedicle screw in S1, you have to actually point your X-ray beam like this. And you can only do so much because of the bed. So you end up kind of guessing and trying to put pedicle screws. You start flipping the X-ray machine AP and lateral. And because of it, was very time consuming. This is another example. This is 53-year-old attorney, and he's got this isthmic spondylolisthesis of the L3-4. He knew this problem, and but he's been dealing with it, but he could not deal with it anymore because his biggest complaint was he could not stand long enough during the cocktail parties. So he decided to fix it. That's his MRI. So this is what I did, and because it is L3-4, not L5S1, what I did was I did an OLIF and put plate and screws from the left side. Now, usually I put ipsilateral pedicle screws on the left side, but I didn't want to do that because I already put a plate and screws from the left side. So it made more biomechanical sense for me to put pedicle screws from the right side. And I tried to do it. It was very difficult because now patient's body is in the middle of the bed, and you try to put K-wires and try to put a pedicle screws from bottom up, and it was quite challenging. I was able to finish the surgery, but it wasn't a very pleasant experience. So nowadays, and I was very proud of being a freehand surgeon, and I used to do everything without any help, no navigation, forget about robots, and I don't use access surgeons. I mean, we all want to be a self-sufficient surgeon, right? But nowadays, because I want to do single-position spine surgery, I find myself resorting for some technology, such as spine navigation, such as robots. So the message here is OLIF and percutaneous pedicle screw fixation is safe, efficient, effective surgical treatment of a grade 2 isthmic spondylolisthesis. And we probably need to do more studies because I'm not quite sure, and I think it is, putting a screws ipsilaterally is just as stable as bilaterally, but I haven't done any biomechanical studies yet. So probably there's opportunity for that. And a future direction is for challenging cases, the ones that I show, I'm not going to be too proud of using spine navigation or robotics. And perhaps this is an opportunity for us to develop more ergonomically correct operating bed as well. Thank you.
Great. Questions? Questions from the audience?
Oh, I actually have one for Dr. Keem back here.
Oh, yeah, let's hold on. And then we'll come back there. Go ahead.
Since these patients are very young. Most of the patients isthmic spondy are young patients. What do you think about the OLIF with bilateral pedicle screw or OLIF with plates, standalone? Or since there are 3 tire fixation, I've done this. Standalone OLIF with plate, only without pedicle screw. Second, OLIF without anterior plate and bilateral pedicle screw. And the third is OLIF without anterior plate with bilateral pedicle screw. There are 3 tire fixation. What do you think about it?
That's a lot of questions. I've been out late drinking, so I'm not sure if I can remember all the questions you just asked.
So how about this? How about the standalone with plate, standalone with posterior screws, or standalone with plate and screws?
So standalone with the plate, and again, I don't think it's going to give you a good enough rotational stability. If you just to put a standalone cage and then put a plate there. And it has been my experience that, and actually there was a biomechanical study done, and without posterior fixation, then that construct's not going to be stable rotationally. And what was the next question again, Dr. Rowe?
I think that was the question.
Okay. And I think you also mentioned that don't put any cage, just put a screws bilaterally. Is that what you said?
I'm asking about how important to use the anterior platings compared with I use only the OLIF with bilateral pedicle screw in single position as well.
Like, do you use a plate with screws every single time?
Not all the time, and I tend to do that if there's any instability, and if there's no significant structural instability, such as a degenerative spondylolisthesis. Let's say that if I'm going to treat L4-5 degenerative spondylolisthesis or spinal stenosis, and as long as the patient's bone stock is good, and if it is osteoporotic, then I like to supplement it with the percutaneous pedicle screws. But as long as the patient's bone stock is good, those are the patients I tend to decompress, reduce, and put an implant and put a lateral plate without the percutaneous pedicle screws.
Question back there from Martin.
Thanks. Dr. Keem, great talk, especially on this OLIF technique. When you take a look at the preoperative MRI, is there anything on the axial sections that make you concerned for the approach? Since you do the approach yourself, when you're looking at the vasculature about if there's enough space for you to mobilize the vessels, or do you even see them during the exposure, or do you just keep them out of the way?
It's a very good question. So OLIF 5.1 does not always work. And I really studied MRI, especially cross-section, very well. If I see a vessel and if I see a vein, which is in the way, but it is nice and round, and that means that I can mobilize the vein during the surgery. If it is flat, it appears to be stuck to the ALL. Now, that kind of vein, you can mobilize it, but in the process of mobilizing it, you end up tearing that. So those are the patients that I avoid doing an OLIF procedures, L5S1.
So do you think, so training-wise, this is different, right? Because it's funny, because when we did A-lifts, obviously we have to use an approach surgeon. When we do laterals, we don't have to use an approach surgeon. Now we're sort of in this gray area, right?
Yeah, sure
So
is.
the training-wise, what would you suggest with respect? Because you're doing this on your own now.
I am.
But what would you recommend is the safest way for surgeons not doing this on a regular basis to sort of transition our way from doing it with an approach surgeon than doing it alone?
That's a great segue question for my. Actually, I didn't bring the slides here. So when I first started doing OLIF 5.1, and it was scary, right? Because I wish I paid more attention, during my general surgery rotation. But we don't do that. We were gonna be orthopedic surgeon. We were gonna be a neurosurgeon. So we rather take a nap than actually going there and then try to see what these guys are doing. So I had to study anatomy, and still it was not good enough to calm my nerves. So this is what I did. And when I first started doing OLIF 5S1, by then, I've done about 50 OLIF 4.5, 3.4, and 2.3. So I knew how to make an approach to the retroperitoneum with OLIF 2-5. So what I did was, I tried to, during the OLIF 4.5 or 3.4, 2.3, I tried to mobilize peritoneum as much as possible, sweep it all the way to the front. And then I put my fingers in there from 4.5. I direct it to anteromedially until I reached to the point that I could make incision to perform OLIF 5S1. So OLIF 5S1 incision is gonna be approximately 4 centimeters in front of the iliac crest, and it's gonna be right above the inguinal canal. So I mobilized retroperitoneum as much as I can and push down the peritoneum anteromedially as much as I can. And I started dissecting when my finger was tenting. And then I went layer by layer until I could find my own gloved finger. Then I knew I was in the retroperitoneum. Okay, so later on I got smarter, and instead of sticking my finger, I had my assistant to put his finger in there. So, I don't want to damage my finger. So I've done that for first 5, 6 cases, and then I was able to confidently approach 5.1. So I think it's actually a great approach, in my mind, and for this person somebody who's about to do 5S1 the first time, it's kind of a nice training wheel. And even for the experienced surgeons, sometimes it becomes handy. For somebody who's very obese, then you don't know where you are, and it could be a nice supporting tool. And so that's how I started doing it.
Do you think these procedures, especially the ones that you did, could be done? I'm saying even, let's say you just do a standalone anterior, anterolateral, right? Could they be done outpatient, do you believe?
I strongly believe that this is going to be done in the outpatient setting, and matter of fact, that's what I'm trying to do nowadays. As you know that our compensation is dropping, and outpatient procedure done in the ASC is a lot more efficient than done in the inpatient. So that's the trend. So the reason why I started doing this in the single position spine, a single position, is that with doing this procedure in AS setting in mind.
Great. Thank you so much, Sean.
Thank you.